Welcome to this video lesson focused on the posterior side of the knee. We will start with a quick review of the anatomy of the posterior aspect of the knee, which is often referred to as the popliteal fossa. The popliteal fossa is a diamond-shaped area that is limited superiorly and medially by the semimembranosus muscle and the pes anserinus muscles. The semimembranosus is one of the hamstring muscles. Its distal insertion is complex. However, its main tendon, or direct arm, inserts on the posterior medial side of the tibia. For the pes anserinus muscles, the most superficial and lateral one, with the highest myotendinous junction, is the semitendinosus. Medially, we find the gracilis, and even more medially the sartorius, which has the lowest myotendinous junction. These three terminal tendons insert on the anteromedial side of the tibia, passing over the distal end of the medial collateral ligament. Lower down and towards the middle, the popliteal fossa is defined by the condylar insertion and the muscle belly of the medial gastrocnemius. Above and laterally, we mostly see the muscle belly and the tendon of the biceps femoris, which we can follow until it inserts on the fibula. The inferolateral portion of the popliteal fossa is defined by the retrocondylar insertion of the lateral gastrocnemius and its muscle belly. In the middle of this diamond is the neurovascular bundle, with the popliteal artery being the deepest. A bit more superficial and in contact with the artery is the popliteal vein, and even more superficial is the division of the sciatic nerve into the common fibular nerve and the tibial nerve. To analyze the popliteal fossa, the patient should be prone. We can start the exam on the medial side of the popliteal fossa by positioning the probe to generate an axial view on its superior portion. At this level, it's easy to find the muscle belly of the semimembranosus, a large muscle belly, and above it, the cherry on the sundae, the tendon of the semitendinosus. The semitendinosus tendon is the most lateral of all the pes anserinus tendons. It has the highest myotendinous junction. If we slide the probe a bit medially, we find the muscle belly and the tendon of the gracilis. And finally, even more medially, is the muscle belly of the sartorius. This is the muscle belly that is the lowest of all the pes anserinus muscles. At this level, we are looking for possible bursitis, and a tendon rupture is also possible in the context of a knee injury. We now take a more distal view to locate the muscle belly of the medial gastrocnemius. If we slide the probe upwards, we can go all the way up to its posterior condylar insertion. Analyzing its insertion is difficult on an axial view, so we rotate the probe 90 degrees to get a sagittal view, making it easier to analyze. Muscle injuries are rare in this area, but should not be overlooked. We will now analyze the relationship between the medial gastrocnemius and the semimembranosus. Between the two is a small common bursa, which can be the source of popliteal cysts. These popliteal cysts can present differently. They may be compartmentalized, multilobed, contain osteochondromas, but also have thickened walls. Quite often they burst, and the fluid collects under the fascia, either superficially or deeply. The symptoms are very obvious, bringing with it the fear of deep vein thrombosis. As you can see, these popliteal cysts can have various shapes. Nevertheless, they always originate from this common bursa, at the interface between the medial gastrocnemius and the semimembranosus. We continue our analysis by looking at the direct arm of the semimembranosus tendon. It's easy to find, on an axial view, in front of the condylar cartilage. Rotating the probe 90 degrees allows you to see the end of this direct tendon on the posterior medial side of the tibia. This is a good time to analyze the posterior condylar cartilage and especially a bit deeper the meniscal rump, which is the site of tears and cysts. Next, let's look at the lateral compartment. We can start with a proximal axial view of the muscle belly of the biceps femoris. The biceps femoris has two heads. The long head is superficial and the short head is deeper. We can follow these two heads until they insert on the fibula. The long head ends a bit earlier, and we will follow the short head until it ends in the distal tendon of the biceps femoris. More distally, we can analyze the lateral gastrocnemius. Still on an axial view, we can locate the muscle belly in the upper third of the calf. Then, we can slide the probe upward until we reach its condylar insertion. This insertion is better seen with a sagittal view if we rotate the probe 90 degrees. Under the lateral gastrocnemius, we can find the muscle belly of the plantaris muscle. Behind the lateral condyle, we can sometimes see a small sesamoid bone, the fabella. Like in the medial compartment, we aim to analyze the posterior condylar cartilage and also the meniscal rump. We end with the neurovascular bundle in the middle, still with an axial view. We locate the popliteal artery deeply. As you can see, the popliteal vein is not visible when the knee is fully extended. We need to ask the patients to slightly flex their knee and release the pressure on the probe until this vein appears. Note that this vein must be in full contact with the artery. Any muscle interposition between the two is suggestive of popliteal entrapment. We will now try to analyze the nerve structures superficially with the tibial nerve. We can use the elevator technique to go up to the sciatic nerve, which we see here under the biceps femoris, and then go down to follow the common fibular nerve under the muscle belly of the biceps into the lateral compartment. This common fibular nerve will give a small branch, the lateral sural cutaneous nerve. At this level, we can look for nerve thickening, suggestive of neuritis, or extrinsic compression, but also a potential tumor as schwannoma. The last step of the examination of this central region is a deeper analysis of the intercondylar notch. Using a sagittal view, we rotate the probe 90 degrees and locate the tibial insertion of the posterior cruciate ligament, which we can follow over its entire course. As you can see, analyzing the popliteal fossa goes beyond simply looking for cysts. A large number of joint, muscle, and tendon pathologies are clearly visible on ultrasound. This concludes our analysis of the popliteal fossa. Thanks for listening. I hope that you found this training useful. I really want to grade General Electric, Canopé, and Maxim's 2 knees. And now, the probe is yours.